others have Black Mondays, and we in the mental health profession have borderlines. Why? Why is it that we spend so much time and energy working with only some patients on the unit or on the ward, and these same patients will inevitably be the ones who turn around and say, I didn't get enough help. I don't feel any better. Numerous issues, numerous frustrations come to mind when even considering borderline pathology. Unfortunately, the more we look for clear-cut answers, the more muddled it gets. Borderlines are kind of like the Rorschach ink blot test. They're ambiguous, they're demanding, they're hard to get a handle on. And how we perceive them, how we treat them, oftentimes has a lot to do with our own emotions, our own state of mind. This presentation will focus on issues relating to diagnosing and treating a borderline patient. It will not be an exhaustive review of these areas, and that's a good thing because working with borderlines is exhausting enough. First of all, diagnosing borderline. A number of issues need to be considered here. The concept of the borderline originated to describe a state falling somewhere between neurotic and psychotic. The borderline schizophrenic is a person who is not quite schizophrenic, but could deteriorate to a schizophrenia if given the right set of circumstances. Now, this way of viewing psychopathology is being on a continuum, with normal at one end, followed by neurotic, then borderline, and psychotic. This way of looking at psychopathology has given way to the point of view that various disorders are discrete, independent entities. Rather than viewing psychopathology as all being more or less intense versions of the same thing, the current view has each disorder being qualitatively different, unique. Much like being pregnant or even circumcised. You either are schizophrenic or you're not schizophrenic. The term borderline continues to be used, though it no longer describes a condition falling somewhere on the border, but rather it describes a personality disorder with recognizable patterns associated with it. DSM-3 uses an axis system in diagnosing psychopathology. Axis 1 refers to pathological disturbances. Such disturbances usually have an acute onset. They tend to follow the course of an illness. And they're usually related to such things as an affective disturbance, a thought disorder, a neurological disorder, or a drug abuse or a drug-induced condition. Schizophrenia, bipolar disorder, major depression, organic brain syndrome, these are Axis 1 diagnoses. Axis 2 refers to personality disorders, characterological disturbances, character disturbances. While Axis 1 looks at the acute pathological symptoms, Axis 2 takes a look at the more chronic, enduring patterns of thinking, feeling, and relating to one's environment, and how these patterns affect a person's adjustment or maladjustment. Borderline pathology is considered an Axis 2 diagnosis. It's the borderline personality disorder. In diagnosing a borderline, DSM-3 suggests that at least 5 of the following 8 symptoms or features are evident. This is straight out of DSM-3. The first one is impulsivity or unpredictability in several key areas of the patient's life, which are potentially self-damaging. Borderlines display pathological patterns of gambling, of sexual acting out, of self-abusive behavior, of drug abuse, of self-mutilated behavior. Second feature is patterns of unstable or intense interpersonal relationships. Borderlines will display devaluation in a relationship. They'll devalue the other person or devalue themselves, or idealization. They'll idealize the other person or idealize themselves, or just a lot of manipulation. Third feature is intense or inappropriate anger, or lack of control of anger. Borderlines are they're terrific temper tantrum throwers. Fourth feature is an identity disturbance manifested by uncertainty in several major areas of the patient's life which are related to their identity. The borderline sense of self, their self-image is impaired. Their gender identity is oftentimes confused. Their long-term plans, their vocational plans, their friendship patterns, oftentimes disrupted. Fifth feature is affective instability. Borderlines have mood swings all the time. They're shifting from normal to angry, depressed, anxious moods. These mood swings generally last for only a couple of hours, and rarely longer than a few days before a return to a normal mood. Sixth feature is an intolerance of being alone. Borderlines make frantic efforts to avoid being alone. Seventh is physically self-damaging acts. One of the most characteristically borderline features are suicide attempts, suicide gestures. But borderlines also do things like they take reckless chances, they take unnecessary risks, they get into accidents, they get into fights. Also, they're self-mutilated. Finally, the eighth one is chronic patterns of emptiness or feelings of boredom. Now, reading DSM-3 would have you believe that diagnosing the borderline is something of an exact science, and it's just not the case. These 8 symptoms, these 8 features that are described, do describe borderline tendencies quite nicely, but they don't necessarily differentiate a borderline too easily from other personality disorders described in DSM-3. DSM-3 discusses a narcissistic personality, a histrionic personality, a dependent personality, and even a passive-aggressive personality, which can be very difficult to differentiate from a borderline. Furthermore, the widespread occurrence of these 8 symptoms or features in a general clinical population, in a general population, creates a situation where nearly everybody is suspected of being a borderline. Now, I think there are some personality disorders described in DSM-3 that are distinctive and unique. The personality disorders that focus more inwardly, like the paranoid personality, or the schizoid personality, or the compulsive personality. And I think they're very much distinct from a borderline. I think it's important to be able to distinguish a borderline from an antisocial personality. Both will act out, but only the borderline will feel guilty about it afterwards. To keep this discussion in perspective, though, for many years it was adequate for diagnostic purposes to simply determine that a person had a personality disorder without specifying what kind of personality disorder they had. To have a personality disorder meant that you weren't mentally ill, that the emotional turmoil, the depression, the anxiety that you felt was somehow not authentic, somehow not genuine, not a primary condition. The thinking was that these patterns of emotional turmoil were chronic in nature, long-term patterns that somehow must work for the patient, somehow must have a secondary gain for the patient. The prognosis for change for these patients was thought to be very poor. Clinical experience taught us that they really weren't hurting badly enough to change, in spite of their claims. Now, these issues that have become associated with a personality disorder have largely become associated with the borderline and remain difficult issues today. DSM-3 calls borderline an Axis II diagnosis, a personality disorder. But borderlines do display pathological disturbances in affect and thinking and behavior. Borderlines frequently carry additional diagnoses of major depression, schizoaffective disorder, atypical psychosis, intermittent explosive disorder, atypical impulse disorder, the list goes on and on. And DSM-3 provides an access system which accommodates this. And I think it's a good idea because it does allow us to specify, to clarify what are the symptoms that a borderline is displaying. Borderlines do have major depression. They do display schizoaffective disorders. They do have atypical psychoses and so on. However, questions regarding the true nature and etiology of these symptoms remain. Further confusing the picture is the chameleon-like tendency of borderlines to take on or mimic symptoms they see in patients around them. In psychiatric hospitals, before the development of anti-seizure medication, a common observation made was that while many patients would have seizures on the ward, certain patients would display pseudo-seizures. And the common thought about it was that these were hysterical symptoms. Although by our present-day understanding, such patients would likely be considered borderline. However, while our clinical understanding of borderlines increases, so does the savvy of a borderline. When a borderline claims to hear voices, it's not as easy as checking out the authenticity of the seizure. On the other hand, it would be extremely dangerous, at least foolish, to dismiss the pathological claims of the borderline. Clinical experience teaches us that such claims have a real meaning for the borderline, if not a basis in reality, though they may have both. Furthermore, borderlines are determined people who have an amazing resilience to the old axiom, ignore it and it'll go away. While the true nature of a borderline and the borderline symptoms remains elusive, the symptoms they display are often easy to identify, easy to track